Now, if we look at what I would like to do is the first mesocortical system, causing those repetitive and exaggerated behaviors and forcing the people to actually suffer some of the positive symptoms. It is only fairly recently that serotonin has become more relevant, particularly with the observation of serotonin's role in depressive mood. So the idea really would be to try and block the effect of dopamine and therefore use an antagonist. The problem would be to try and raise levels of serotonin together with blockade of dopamine. A blockade of dopamine receptors, that's easy. How about for serotonin? How can I improve serotonin neurotransmission by using an antagonist? Well, if you work on certain 5-HT2 receptors in the mesolimbic system, blocking them actually will help those negative symptoms. And that is primarily because in those neurons, 5-HT2 receptors are to be understood a little bit like the alpha-2 receptors on norepinephrine terminals, in that if they're located presynaptically, they actually would normally negatively feed back on serotonin synthesis and release. And if you block 5-HT2, then you prevent that negative feedback and improve serotonin neurotransmission. Besides, this works for negative symptoms. And that is primarily because in those neurons, 5-HT2 receptors are to be understood a little bit like the alpha-2 receptors on norepinephrine terminals, in that if they're located presynaptically, they actually would normally negatively feed back on serotonin synthesis and release. And if you block 5-HT2, then you prevent that negative feedback and improve serotonin neurotransmission. Besides this work hypothesis, you also have another one. Neuroanatomists have shown that in the mesolimbic system, you have a balance between dopamine and serotonin. It's a balance that is very similar to the one we've reviewed in the nigrostriatal pathway between dopamine and acetylcholine. Here, basically, the idea is if there's too much dopamine, there's too little serotonin. If there's too much serotonin, there'd be too little dopamine. They're in balance with each other. So once again, blockade of 5-HT2 receptor here could be thought that actually also as improving the dopamine neurotransmission because of this balance. Whichever way, when a drug will block both dopamine and serotonin receptors, it will be what we call an atypical antipsychotics. And atypical antipsychotic are some of the more novel medication in managing psychosis. Now, if schizophrenia is the main form of psychosis, schizoaffective states, parts of bipolar disease, particularly mania, will see the use of these drugs very readily. Other important uses, dopamine antagonists are also used in Tourette syndrome. You may want for Tourette to remember one drug, which is pimozide. I'm writing there at the top, and that's an anti-dopaminergic drug. Pimozide that is used in Tourette syndrome. And then let's not forget that dopamine antagonism will be a strong antiemetic. You can actually use it as an antiemetic in chemo and radiotherapy patients. So I'm looking at side effects of antipsychotic medication. That is generally where the money is on your step 1 board question. Side effects of dopamine receptor blockade. Well, they have to include dyskinesias. These dyskinesias, we call them extrapyramidal symptoms. extrapyramidal symptoms are just ranked here as EPS. Those dyskinesias are to be seen chronologically because the dopamine pathways and movement initiation is critical to our body function. You can imagine that the brain will very quickly try and adapt to the blockade of its dopamine receptors by a drug. Acutely, it will be surprised, and it will be so surprised that the dopamine blockade will mimic the disease Parkinson's. Remember, in Parkinson's, we don't have dopamine because we destroyed the nerve. Here we do have the nerve, we do have dopamine, but we've blocked its receptor. Well, this initial finding may literally occur within hours of initiation of a treatment. It is what we call pseudo-Parkinsonism or drug-induced Parkinsonism. This pseudo-Parkinsonism has all the classic findings of the disease itself, with bradykinesia, with resting tremor, and with rigidity. That pseudo-Parkinsonism is going to quickly lead within potentially days to dystonias. Dystonias being that the muscle rigidity becomes pretty severe to the point of being spastic-like with pain from the actual dystonia. Classic dystonia would be for the patient to have torticollis, for instance. You know, that is a stiff neck, when your head is just stuck on one side like this and you can't move it at all because it hurts so much in your neck. Now, all these are very much associated with the actual acute blockade of the dopamine receptors and in a way can be managed as you would Parkinson's disease. Two choices: increase dopamine with drugs like levodopa, selegiline, tolcapone, and entacapone, or block muscarinic receptors. The choice is yours. What do you choose? I'm sure you're answering anti-muscarinic drugs and not dopamine-like drugs. Of course, if you were using levodopa to treat these symptoms, well, you would exacerbate the psychosis of the patient. So anti-muscarinic drugs are pretty much the management of these acute EPSs. Now, let's go a little bit beyond days and maybe now go weeks into the treatment. With weeks into the treatment, we are now talking time for adaptation. And the whole idea is as follows. Let me take a little diagram for you right here. And what we shall do is an actual postsynaptic neuron and put on it a few dopamine receptors. And those dopamine receptors are going to be D2 type of receptors. Upstream, I'm going to make a nerve terminal that can actually release dopamine. And now in blue, I'm going to put a drug that blocks some of the dopamine receptors. So initially, through the drug blocking some of the dopamine receptors, we are seeing less dopaminergic transmission, and we're seeing Parkinson's disease, we're seeing some issues with possibly some dystonias. What will happen readily within weeks? Well, you see that one single receptor here that is left can first become very sensitive, what we call sensitization. And once it becomes hypersensitive, it's going to try and do the job of 3. And as such, reinstate now excessive neurotransmission in the nigrostriatal pathway as a consequence of the actual drug blocking some of the receptors. This is a situation that would result then in too much movement. And too much movement, maybe the first thing we'll see is what we call akathisia. Akathisia is the compelling need to move. This is a patient who cannot sit still, who will be standing, sitting on end like this for hours, or maybe just bouncing back and forth from left leg to right leg, or just slapping their hands on their thighs non-stop. Akathisia is really troublesome. Now, sensitized receptors, what you could try and do is literally increase further the dose of your antipsychotic to block it. Fine. So it is still manageable. But what your book tells you is that ultimately you'll go from that compelling need to move, which takes weeks to occur, akathisia, to what we call chronic or tardive dyskinesias. And tardive dyskinesias, unfortunately, they may take months to occur, and they're often irreversible. Now, what are tardive dyskinesias all about? Well, let me go back to the diagram that we're building at the same time. If I go back to this diagram, ultimately, this is what the cell is going to decide to do. It's going to fire more dopamine, and it's going to now cause plenty more receptors to be made to that dopamine. Plenty more receptors, that's going to be called now not sensitization, but upregulation. That is, increase the number of receptors. This is, if you want, in terms of biochemistry, an increase in Vmax, whereas sensitization, you didn't change the number, you've increased the affinity for the binding. So if you want, this is a change in Km. And let's not forget that Km is inversely related to affinity. With upregulation, now you're getting what we call tardive dyskinesia. That is literally your patient is becoming totally hyperkinetic and very similar to a Huntington disease type of patient. So that tardive dyskinesias are hyperkinetic disorders associated with choreiform movements, with writhing of the torso, some grimacing and facial twisting, protrusion of the tongue, and so forth, which will be really dramatic for the patient because they would like not to look this way and they can't help it. With this upregulation, what do you think would happen if you were further increasing the doses of your dopamine antagonist?
Stress means increase number of receptors, मतलब upregulation. First मतलब increase Vmax. Nice.
You are correct. The more you increase the antipsychotic, the more likely these receptors will upregulate further, and the worse the tardive dyskinesias would become. So then in turn, you might think, okay, then I will have to stop the antipsychotic and hope that the receptors return back to our three original...
What's the cornea transplant and multiple sclerosis? Are they related? Yeah. Cornea transplant and multiple sclerosis. Okay. I don't know it. Let me check. क्या वो काजल नहीं यार CK Jacob disease transplant and Rotterdam price disease price. That cost. See, JD what price?
No receptors in this diagram. The problem with this is that for reasons that we're not sure of, quite often those plastic changes in dopaminergic synapses of the nigrostriatal pathway are irreversible. So tardive dyskinesia is literally one of these situations that we're going to try and avoid if we can by using newer antipsychotics. Problem with new antipsychotics, they don't have the clinical background that the older ones have, and sometimes don't have the same efficacy. But nonetheless, a switch to an atypical drug is going to be a potential management rather than pure discontinuation and internalization of your patient into a special institution, simply because your patient is now going totally nuts with psychosis. Now, is that the only effect of dopamine blockade, that of dyskinesias? Certainly not. I'm sure you can think of many other things based on the first page of this section 6. Obviously, dyskinesias are the important story as far as you examine their limiting side effects. But let's not forget that our patient will be unhappy. That dysphoria comes from blocking receptors in the mesolimbic system, maybe fighting psychosis, but also fighting reward, fighting pleasure. Dopamine and mesolimbic does make someone feel happy, feel good about themselves, and wanting to repeat whatever behavior we said they had done to have this happen. Dysphoria here means these dopamine antagonists will worsen negative symptoms of schizophrenia. This is where working on serotonin is going to be quite relevant to help this patient's dysphoria. What else could we bring about from dopamine antagonism? Well, certainly the endocrine dysfunctions, being that I'm blocking dopamine, and this time I'm talking as a psychotic patient that this is an individual who's going to be maybe in his or her 20s, maybe even a teenager. So when you think of prolactin here, it will be relevant for side effect. Tell me a little bit, what do you think will happen to prolactin levels in this young individual? If you block dopamine, you're relieving the inhibitory effect on prolactin. Therefore, you'll see an increased prolactin. I'm going to call it PLT. And prolactin being increased, that should be associated with gynecomastia in males, with certainly some amenorrhea potential in females. Now, that's not the only thing that is endocrine. Remember the effect on food intake. You are correct in thinking you're going to start eating much more, and you're going to have weight gain as a classic side effect of these medications. Weight gain has recently been studied in people with antipsychotic medication. You see, we've used antipsychotics since the 1950s. There were young patients then, there should be old patients today. Well, here's the surprise. Clinical studies cannot find these older patients. They've already died. The life expectancy of someone on antipsychotic is actually in their 50s. And what studies have shown is that diseases such as obesity and its related disorders, such as diabetes type 2, cardiovascular diseases, cerebral vascular diseases, are generally far more common in the population taking antipsychotic than the general population. Does it mean this weight gain has clinical relevance? It probably does, and certainly has been a board point for a long time about antipsychotic. It's even more relevant today. The final point about endocrine dysfunction, let's not forget the temperature regulation effect of dopamine. By blocking it, the thermostat is going to be messed up. And messing up the thermostat, you're going to have the potential for malignant hypothermia. That is about antipsychotic. It's even more relevant today. The final point about endocrine dysfunction, let's not forget the temperature regulation effect of dopamine. By blocking it, the thermostat is going to be messed up. And messing up the thermostat, you're going to have the potential for malignant hypothermia. That malignant hypothermia is really referred to primarily as a neuroleptic malignant syndrome, so that we don't confuse it with the one associated with succinylcholine. But it's very similar, except this time, instead of starting at the level of a skeletal muscle from depolarization, we are working in the central nervous system with a drug that is interfering with a thermostat in the brain. Further, the dopamine antagonism, let's not forget, causes increased rigidity of the muscle. So also in increasing electron transport chain. Big difference with malignant hypothermia, the idea of using a dopamine agonist drug in order to fight the effect of the antipsychotic. This is the use of drugs such as bromocriptine or such as pergolide. Remember, bromocriptine, pergolide. These are two dopamine agonists that would kick the antagonist off its receptor. Of course, we know those well because the rest is the same as a malignant hypothermia from succinylcholine, which is the use of dantrolene to try and prevent calcium release from DSR, and supportive management such as cooling blankets and so forth in order to make sure that the patient survives this. That neuroleptic malignant syndrome is more likely with a very potent dopamine antagonist drugs. The final side effects of antipsychotic medication will be associated with those of muscarinic antagonism and alpha antagonism. None of these pharmacological effects have anything to do with fighting psychosis. They literally have only to do with side effects, being atropine-like and prazosin-like. The last time we saw that was indeed with the drug quinidine. So these drugs are quinidine-like in their effect. Now, don't you dare use the word synchronism here, being that antipsychotics are not derivative of quinine, but it's the same story. Atropine-like side effect, we already reviewed earlier on. Alpha blockade is the potential for hypotensive episode with reflex tachycardia, but it literally
sclerosis. Schizophrenia. Mischief, mischief asthma. Serotonin receptors. पहिले बाटोको थाहा छैन मलाई होइन. Oh fuck. Wait. ठंड पड़ गया है. त्यो लाइट के लाइट लाइट पड्क्यो झन्डै अलिअलि पऱ्यो खोइ अब पड्क्यो काम गर्छु गर्दैन अहिले चेक गर्दिनँ पछि चेक गर्छु मुनि हाततिर कि के भयो काँडा के भयो भनेर सुन त अहिले यो ठिक छ अहिलेको लाइट अहिले मैले त्यो लाइट बन्द गरिदिएँ कि मैले धेरै आँखा खायो अनि यस्तो हुनुपर्छ क्यामेरा उतापट्टि छ Hold on. Serotonin. कुनै आर्टिकल छ कसरी पढ्ने त यार झरेको कि पड्केको होइन मैले बन्द गर्दा थिएँ लाइट अब लाइटको बन्द गरिदिएको अनि पड्केको आफै अनि झरे होइन पड्क्या हो हल्का कालो छ त्यो यसलाई यो लाइटले आँखा खायो कि अहिले यतिकै स्ट्रिम गरौँ न ठिक्कको लाइट ल्याउनुपर्छ यतिकै ठिकै आएको त्यस्तो नराम्रो आएको छैन दिमाग हान्दैछ यार के गर्छु ल 5:1 1 को एबिसी पाँचवटा लाइब्रेरी छ 2 को एबिसी 3 4 5 6 मा कति रिसर्चहरू यार पहिला त 1 देखि 6 7 थियो 1 को सबटाइप 2 को एबिसी खासमा काममा चाहिने पनि 2C मा चाहिने पर्ने हो केमा ब्लक गर्छु Hold on 14.5S2T D2C nice done जस्तै एन्टिडिप्रेसेन्ट होइन हामीलाई चाहिएको एन्टिसाइकोसिस साइकोटिक कारण साइकोटिक T2 6 subscribers no boys dopamine kasa dopamine what is dopamine I need dopamine that's why dopamine password restricted side D2C that's D2C so you see that's D2C it's really big होइन moment mode close up in sorry, it's 2A होता 5HT2A platelets cerebral cortex. जस्तै 5HT2 एक छ हामीलाई थाहा हुन्छ सेरेब्रल कर्टेक्स बनाउनु प्लेटलेट्स भने नाइस त्यही भएर अग्रानुलोसाइटोसिस दामी अनि 2C हिप्पोक्याम्पस र सायद नि त्यो पनि लेखौँ न हिप्पोक्याम्पस सब्स्टेन्सिया निग्रा के हुन्छ नाम रहेछ अरे
apparently have only to do with side effects, being atropine-like and prazosin-like. The last time we saw that was indeed with the drug quinidine. So these drugs are quinidine-like in their effect. Now, don't you dare use the word synchronism here, being that antipsychotics are not derivative of quinine, but it's the same story. Atropine-like side effect, already reviewed earlier on. Alpha blockade is the potential for hypotensive episode with reflex tachycardia. And let's not forget the 3C's potential from antimuscarinic with torsade, convulsions, and coma being an issue. So let's look at some individual antipsychotic drugs by using the big tables that will conclude this chapter. This table is to be seen in two halves. First drug groups are the typical antipsychotic. Typical antipsychotics are called this way because typically what you expect a drug to cause, if it's called antipsychotic, are EPSs. Remember, those extrapyramidal symptoms associated with dopamine receptor blockade. Notice further that besides the dopamine block that classically causes dyskinesias, let's not forget that all antipsychotics have some degrees of muscarinic antagonism and alpha antagonism. It does mean solely on the muscarinic antagonism that these are drugs that should be fairly strongly sedative. The last column will observe other characteristics that might be relevant for board question or simply clinically about the drugs that we are looking at here. In the typical antipsychotic, you will often see azine as part of the name. That's because they are part of a chemical group that we call pheno, I don't care too much about the pheno, thiazines. I do care about two things in that second half of the word. Thia, because it tells me I could have non-dose related allergies in my patients from sulfonamide hypersensitivity. Azine, because it recalls to me that things in azine are classically antipsychotic medication. Well, the oldest of all is the drug chlorpromazine. If you want, it's the prototype of these antipsychotics. Cyridazine, flufenazine are also some important ones to have in mind there. When I'm looking at these drugs, let's focus a little bit on cyridazine. It has a key point. This is the strongest antimuscarinic and alpha-blocking drug. It is also, therefore, one of the most sedative, one of the most CNS depressant from that matter. Cyridazine, then, is far more likely to be called quinidine-like than any of the other drugs. Quinidine-like with a potential for cardiotoxicity, torsade, and let's not forget the potential for convulsions. Convulsions from lowering the seizure threshold in our patients. Otherwise, coma on overdose would be expected. Cyridazine, by the way,
ब्रेक भएछ यता 1:52 2 बज्यो 10 मिनट ब्रेक गर्छु बस्दाखेरि भोमिटिङमा हुन्छ पढाइसम्म जानु जगाइसक्यो हो right back. This is crazy. The article went down another download. त्यसमा राखिन्छ पढ्नु हुन्छ पछि धेरै लाउँछ यार कहिले पढ्ने त अफिस सुरु गर्नुपर्छ पढ्नु है टाइममा राख्दै फेरि पछि 50 मिनट्सको राखिदिन्छु है यो टाइममा ओके not more than 50 minutes ठिकै 3 बजे सुत्नुपर्छ उजुल हेरेर आएको तिमी and I'll be right back. This is crazy. कसरी गर्छ कि त्यही नबुझिरहेको छु भिडियोहरू पनि बुझ्दैन कस्तो schizophrenia भयो schizophrenia सेरोटोनिन पनि रुलै दिएको छैन म त्यत्तिकै भइरहेको थिएँ होइन स्किजोफ्रेनियामा सेरोटोनिनको कुनै रुलै छैन त्यसो भए why to block serotonin receptor लाइट नभइसक्यो यतापट्टिको बत्ती पनि गयो अहिले त नो डाटा अरे किन डाटा आएर छ त I'll be right back. This is crazy, but he's my number, so call me maybe. यो क्वेसन दामी क्वेसन छ होइन यसलाई चाहिँ म के गर्छु भन्दाखेरि यसलाई bookmark. Yes. पछि हेरौँला आर्टिकल जानु पर्यो काम छैन जर्नल पढ्ने त डाउनलोड गर्नु मिल्दैन त्यसो भए नपढौँ
It has always been an issue also for causing retinal deposit. Chlorpromazine, if you want to know, is more relevant for corneal deposits. So problems with vision can also occur because of this. Now, another point about thyroidazine. We know that the acute dyskinesias are primarily due to that dopamine antagonism and consists of pseudo-Parkinsonism and muscle rigidity with dystonias. How did we decide to manage those acute?
How antipsychotics. Psychotics. Block muscarinic. प्लस 2a एन्टागोनिजम 1a अगोनिजम रे फेरि ल हमा कडा यार one a का छ राफिनिटीमा राफिनिटी क्लाम्सियोडर निकाल्ने हो हैन हो त अनि यिनीबाट रहेछ so disturbing there.
In this video, I talk about the mechanism of action of first and second generation antipsychotics. I will discuss the mechanism of action of aripiprazole in another video. So this slide is an outline of the key topics we are going to discuss in the following minutes. First, we'll see how all antipsychotics reduce dopaminergic neurotransmission. Also, we will review the dopamine hypothesis of schizophrenia. And finally, I will present some relevant pharmacological properties of second-generation agents, such as 5-HT2A antagonism, fast dissociation from D2 receptors, and 5-HT1A agonism. So let's start by answering this very important question. What do all antipsychotics have in common? The answer is relatively simple. They all reduce dopaminergic neurotransmission. In the upcoming slides, we'll see how and where this takes place and why dopaminergic blockade is important in psychosis pathophysiology. Now, we'll study how antipsychotics reduce dopaminergic neurotransmission. There are two options. The first is through D2 antagonism. Both first and second generation antipsychotics can block D2 receptors. The second option is through partial agonism. At this time, the only approved third generation antipsychotic is aripiprazole. We'll discuss its mechanism of action in another video. As we discussed in the dopamine pathways video, there are four pathways key to antipsychotics pharmacology. Blockade of two of these pathways can lead to adverse effects. The other two pathways are relevant to schizophrenia symptoms. In this figure, the mesolimbic pathway is shown in blue. The dopamine theory postulates that positive symptoms such as delusions, hallucinations, and thought disorders are caused by an overactivity of this pathway. In the other figure, here, the mesocortical pathway is depicted in red. Recent findings suggest that the dysfunction of the mesocortical pathway may be a part of the neurobiology of negative and cognitive symptoms. So, in review, excessive activation of the dopamine mesolytic pathway is related to positive symptoms, while negative and cognitive symptoms might be caused by mesocortical dysfunction. The dopamine hypothesis of schizophrenia postulates that postsynaptic dopamine antagonism is a common mechanism that explains antipsychotic properties. The pharmacologist and clinician Stephen Stahl argues that it would be more appropriate to refer to this theory as the dopamine hypothesis of positive symptoms of schizophrenia. The reason is that there are more pathways and psychopathological dimensions that are not included in this theory. Oh, so what is the evidence that backs up the dopamine hypothesis of schizophrenia? The risk of drug-induced psychosis is very high with drugs that increase synaptic dopamine availability. This includes drugs such as cocaine, amphetamines, and levodopa. In fact, psychosis can be a potential complication for patients suffering from Parkinson's disease treated with levodopa. As I mentioned before, schizophrenia neurobiology is very complex, and the dopamine theory has limitations. The first limitation is that it doesn't explain cognitive deficits in schizophrenia patients. The second limitation is that psychotomy effects of activation of other pathways are not included in this theory. For example, D-lysergic acid is a 5-HT2 agonist that can produce psychotic symptoms. Let's discuss now the mechanism of action of first and second generation antipsychotics. First generation or conventional antipsychotics are D2 antagonists. They lower dopaminergic neurotransmission in the four dopamine pathways. In addition, they can also block other receptors, such as histamine 1, muscarinic 1, and alpha 1, among others. Second generation antipsychotics are also known as atypical antipsychotics. This term was originally used to refer to a low risk of extrapyramidal effects for the antipsychotic clozapine. The other less used term is serotonin dopamine antagonists. This describes one of the key features, which is the ability to block serotonin receptors. One of the most important features of second generation antipsychotics is their 5-HT2A antagonism. In this slide, we'll use clozapine as an example. This is because this was the first drug in the group. Clozapine has a very high affinity for 5-HT2A receptors and a lower D2 affinity than haloperidol. This led researchers such as Herbert and Meltzer to propose that the differential antipsychotic effect of clozapine is related to its high 5-HT to D2 ratio. Another theory of atypicality proposes that second generation antipsychotics dissociate rapidly from D2 receptors. This would be a possible explanation for the lower risk of extrapyramidal symptoms of drugs such as clozapine. This table compares first and second generation antipsychotics in terms of their binding to D2 receptors. Conventional antipsychotics tend to bind more tightly to dopamine receptors than dopamine itself. Clozapine and the other second generation agents bind to D2 receptors more loosely, so in the presence of dopamine, they tend to come off the receptor more easily. This short sequence depicts fast dissociation from D2 receptors. In this image, we can see the loose binding of a second generation agent to the receptor. In this slide, we see that in the presence of dopamine, the drug easily dissociates from the receptor. Now, here we can see how dopamine finally binds the D2 receptor. Another property of second generation antipsychotics is that some of them are 5-HT1 agonists. The second generation antipsychotics in terms of their binding to D2 receptors. Conventional antipsychotics tend to bind more tightly to dopamine receptors than dopamine itself. Clozapine and the other second generation agents bind to D2 receptors more loosely, so in the presence of dopamine, they tend to come off the receptor more easily. This short sequence depicts fast dissociation from D2 receptors. In this image, we can see the loose binding of a second generation agent to the receptor. In this slide, we see that in the presence of dopamine, the drug easily dissociates from the receptor. Now, here we can see how dopamine finally binds the D2 receptor. Another property of second generation antipsychotics is that some of them are 5-HT1 agonists. This includes drugs such as ciprasidone, quetiapine, and clozapine. What is the importance of this? The answer is that 5-HT1A agonism would increase dopamine release in the prefrontal cortex and also reduce glutamate release. PET study and also reduce glutamate release. PET studies show that D2 receptor occupancy predicts
दामी दामी के गर्छ भन्दाखेरि इन्क्रिज डोपामिन डिक्रिज ग्लुटामेट unique money. Nice.
Clinical efficacy and extrapyramidal symptoms. In this graphic, we see that occupancies in the range between 60 and 75% are associated with clinical antipsychotic efficacy. Increasing the antipsychotic dose above 78% occupancy increases risk of extrapyramidal symptoms. So in clinical terms, this means that the optimal dosing of any antipsychotic agent is one that occupies between 60 to 75% of D2 receptors. This table summarizes some core concepts on the mechanism of action of first and second generation antipsychotics.
फेरि त 2A ब्लकर छ 2A कहाँ हुन्छ सेरेब्रल कर्टेक्स 2A 5HT2A सेरेब्रल कर्टेक्स द ब्लक गर्ने हो ओके
Conventional agents are D2 antagonists, while second generation antipsychotics have a high 5-HT2A, D2A agonist. Block muscarinic 1 is
how antipsychotics blockers of the other
saying antimuscarinic, you are correct. And now tell me a little bit about thyroidazine. Is it an antimuscarinic or what? It's the strongest of all these drugs as a muscarinic blocker. As such, it's the only one plus in the EPS column. That is the fact that thyroidazine treats by itself its own acute EPSAs. So it has made thyroidazine really a relevant drug right from the beginning. Now, there's another group of typical antipsychotic that are worth mentioning. The group of drugs that are called something peridol. Haloperidol being the prototype, droperidol, for example, being another one if you want. Haloperidol has the distinction of being one of the worst with fluphenazine for EPSAs. It's because these two drugs are really the more potent dopamine antagonists as antipsychotics. For haloperidol, then points on the exam have always been the clinical fact that it is the most likely of the drugs to cause neuroleptic Marian syndrome and the worst one for its association with tardive dyskinesias. What would you use in malignant syndrome for the antipsychotics? Are you saying bromocriptine or pergolide with dantrolene and supportive management? If you are, that's absolutely correct. And let's not forget this for a board question. How about the tardive dyskinesias? Well, with tardive dyskinesias, either we stop the drug or we switch to an atypical.
Okay.
This next slide starts showing the prototype for the name.
Ada mostly haloperidol Tourette syndrome, Tourette tics, OCD.
Typical antipsychotic. What is key of atypical antipsychotic is that first column, EPSAs, showing you plus or minus, showing you that unlike what you expect from dopamine antagonism, you do not see extrapyramidal symptoms as readily with these newer drugs. The important drug here to review is the drug clozapine. Clozapine is still a muscarinic and alpha blocker, so it's still quinidine-like and can still cause the 3 C's in its intoxication. It is also pretty sedative. But the key point about clozapine lays right here. It's a blocker of D2C, not D2A. Relevance of this. You remember? D2C is in the mesolimbic system, D2A is in the nigrostriatal system.
B2. Nice. D2 बाल छाने के D2 यो किसी mesolimbic can see only mesolimbic they were damn proper weak blocks dopamine weak D2C मा यो भनेको mesolimbic मा जुन हामीलाई चाहियो अब not on D2A यो nigrostriatal so no extrapyramidal syndrome.
If a chemist has dissociated the two receptors with a chemical clozapine, you now have a drug that blocks dopamine transmission in the areas associated with psychosis without doing much to the areas associated with movement. This is the primary reason why you don't see as much dyskinesias. As a matter of fact, out of all of the atypicals, this is the only drug that has never been associated to date with tardive dyskinesia, with the potential of irreversible extrapyramidal symptoms. So that's a massive advantage of a drug clozapine. What else makes it typical? Well, the other thing that makes it atypical is the fact that for the first time, this was a drug that was also established as a 5-HT2 antagonist, therefore a drug that would improve negative symptoms on top of blocking the positive symptoms. What made that drug so unpopular is the unfortunate issue of agranulocytosis. This is not a dose-related effect. It's not like clozapine causes bone marrow suppression like an anti-cancer drug. It's rather clozapine through hypersensitivity causes destruction of white blood cells. Well, it is so severe as to occur in upwards of 5 to 10% of the patients. So we're not talking 1 in a million here. We're talking a requirement for weekly blood tests to do white blood cell count on a weekly basis. That is extremely invasive, impractical, costly, you name it. We don't like this. That has been the demise of the drug clozapine. Besides, it is also a drug that causes significant weight gain, but then so again do all other antipsychotics. So really, that's not the big news here. What might be big news is the issue of increased salvation, wet pillow syndrome. Unlike agranulocytosis, that's not going to kill the patient. I don't think you're going to drown in your own spit while you're sleeping at night on that famous pillow. I think your biggest problem with this is to try and understand it. What would you said, based on dopamine, muscarinic blockade, and alpha blockade, should have been the actual secretion effect of clozapine? I'm sure you're scratching your head thinking, well, I would have said dry mouth. And you know what? So would I. And the idea then is when you see that increased salivation, it does not come from the muscarinic blockade. It actually comes from the serotonin pharmacology. And learning serotonin pharmacology in medicine is literally gathering the points as we see more and more drug working on serotonin receptors. Serotonin pharm is still in the process of being understood. And serotonin pharmacology is so complex, I think probably we have to leave it to people who want to study it for 3 lifetimes in a row to make sense out of it. For us then in medicine, the only point is to associate some points with serotonin receptors. Here, 5-HT2 blockade causes increased salivation. After all, where do you find most of your serotonin? In the brain or in the gut?
Gut.
If you think carcinoid disease and pathology, you realize 90% of the serotonin produced by our body is as a gut neurotransmitter. It helps in digestion. And if it does, maybe, actually, it has some effect on salivation. Whatever the case might be, increased salivation, wet pillow syndrome, a side effect of clozapine.
Okay. अब मैंने 5:2 ब्लक गर्यो 2 भनेको छ अहिले 2 माने एबिसिडी भनेको छैन नाइस दामी स्टोमा पनि छ नि त 2 मा जस्तै 5:2b भनेको स्टोमाको ब्लक गर्न नसकेको छ भयो sorry.
Can you actually tell me what is the reason for the seizures? I'm sure you can tell me. The reasons for the seizures have to be either the muscarinic blockade or the dopamine antagonism. But the 3 C's of muscarinic antagonism will always lower seizure threshold in antipsychotic treated patients. So clozapine has the agranulocytosis as a big problem. Let's see what chemists and drug companies have offered us since. They made an analog of clozapine called olanzapine. Olanzapine is not associated with agranulocytosis, so the day of your exam, they could play with you, giving you a patient who received an atypical antipsychotic, maybe because of tardive dyskinesias, and they were placed on clozapine, developed agranulocytosis, and then your board asks you, what could you do next? Well, with agranulocytosis, you remove clozapine, and then you could use another atypical, a drug like olanzapine, risperidone, aripiprazole, other drugs if you want to put in there drugs like quetiapine, for instance. There's really many atypical antipsychotics. All these atypical antipsychotics preserve the fact that they have little extrapyramidal symptoms, but none of these atypical can result in no tardive dyskinesia as clozapine did. So they're probably not as selective of D2C than D2A, unlike clozapine. They're still muscarinic and alpha blockers. They're still called sedation. The big emphasis in the drug company is the blockade of 5-HT2 receptors. And in their marketing strategy, the big saying is they will improve negative symptoms of schizophrenia. So for risperidone, it's the same thing as olanzapine. For aripiprazole, when you see it board tested, it is the fact that it's also a partial agonist at dopamine D2 receptors. Hey, this is a smart way of thinking. As a partial agonist, you won't be as potent a dopamine blocker, no doubt. But with the synergy of also blocking 5-HT2 receptors, you're probably a very good antipsychotic. Partial agonism does mean ceiling effect for efficacy, but it also means
Wait, nice, 2, 3, 4, 5, 7 hours.
means that it will never totally block the nigrostriatal pathway D2A receptors, so it is less likely to be associated with those plastic changes that we describe for EPSs. Well, this actually concludes Chapter 6, the drugs used in both Parkinson's disease.
Thank you. I'm gonna read now antidepressant.
The title
23 minutes was it? We have 18 minutes left. So no worries. बुझ्यो धेरै बुझ्यो
of Chapter 7 is just about longer than the chapter itself. This is because we're going to place in there the drugs used for depression, the drugs used for bipolar disease, which is primarily the single drug lithium, and we'll just make a little mention of attention deficit hyperactivity disorders. The amine hypothesis of depression was formulated back in the 1950s with the observation that reserpine, the antihypertensive that would destroy synaptic vesicles and deplete norepiserotonin and dopamine, caused a number of patients to suffer severe depression, if not to commit suicide. So the main idea behind an antidepressant has been since then, and it still is today in the 21st century, to increase the levels of norepinephrine and serotonin. Why not increase dopamine? Well, primarily because at the very same time, the dopamine hypothesis of psychosis was also being formulated. And it was well known then that increasing dopamine could possibly render the patients psychotic and also suffer lots of dyskinesias. So emphasis has been placed on norepinephrine and serotonin, but in managing depression. The surprising thing is that if this is the acute effect of a drug, this certainly does not seem to be the therapeutic effect of the drug, being that the antidepressant effect takes several weeks or months to occur, if it ever does, some patient being poorly managed with classical antidepressants. You know, when a drug takes several weeks to exert its effect, it's primarily because it requires changes in gene expression, adaptation here of neural synapses, before you can see the therapeutic effect occur. Now, here, think of it 1 second. If acutely you increase norepinephrine, increase serotonin, it's quite likely that then the idea is that downstream, when I'm looking at the other nerve terminal, what do you think will happen to the actual receptors themselves? Well, the receptors, probably after a period of weeks, are going to desensitize and downregulate. So, of course, it takes time, and those plastic changes must have occurred before we see a therapeutic benefit from using the antidepressant. Maybe another point to bring about then from this statement is if I wanted to switch between classes of medication, would I expect an effect that took weeks to occur to possibly take weeks to go away? The answer is, of course, yes. The same plastic changes to reverse will take weeks. So it means when you switch from one class to another, classically, psychiatrists will wait possibly a period of 10 days to 2 weeks before they really jack up the doses of the other antidepressant, simply because it takes a while for the initial drug to lose its effect. Well, the oldest drugs used in managing depression are the MAO inhibitors. Your boards are fond of MAO inhibitors because of the drug interactions. And it is those drug interactions that tend to result in not using commonly MAO inhibitors in the United States. There are 2 drugs that are MAO inhibitors in your book and on your exam. These are the drugs phenelzine and tranylcypromine. You know, if you don't want to remember too many names of drugs, which we never do we? Maybe those are 2 that are fairly safe to leave behind initially in your review, and simply referring to these drugs as MAO inhibitors seems to be the trend on your exam right now. These are non-selective inhibitors. They block both MAOA and MAOB. So let's review one last time. MAOA blockade will raise the levels of which neurotransmitters? Norepinephrine and serotonin. Of course, for the MAOB inhibition, remember the drug selegiline in Parkinson's. That was the actual enzyme that would degrade dopamine, so MAOB inhibition would also increase dopamine. You see, it seems that these original drugs were actually non-selective of all 3 neurotransmitters that were supposed to play a role in depression. Right now, they're used only as second-line agents for what we call atypical depression. An atypical depressed patient is a patient who does not respond to the classic treatment with reuptake inhibition. Problem with MAO inhibition is the drug interaction that would build up too much norepinephrine, we call that hypertensive crises, or too much serotonin, we call this serotonin syndrome. Too much norepinephrine means in the periphery, massive hypertension from the alpha-1 stimulation, big arrhythmias from the beta-1 stimulation, and in the CNS, potential excitation, hypothermia from a combination of receptors. Well, possibly one of the primary drug interaction to know well about here is that of tyramine with MAO inhibition. We've reviewed this one already as the cheese effect in the autonomic nervous system. It came from the point that tyramine from food has to be digested by MAOA in the gut and liver so that it would cause no release of actual neurotransmitters in the brain. With MAO inhibition, the bioavailability of tyramine is increased and we see hypertensive crisis. Can you actually remind me other releasers? If if you're remembering well, the amphetamines, which I'm going to call AMPs here, the amphetamines, and of course the derivatives of ephedrine, which can be used in cold medication and as psychostimulants, well, then you're doing good. These are all your major releases, and they would all enter in drug interaction with MAOA inhibitors. How about our next group of drugs, the TCA, tricyclic antidepressants? They block reuptake. And as they block reuptake, they do it for both norepinephrine and serotonin. So TCAs are found both as drugs that could increase the levels of norepinephrine to the point of a life-threatening hypertensive crisis, but also in our next section about serotonin syndromes. Alpha-1 agonist, classically over-the-counter as cold medication that would worsen the risk of hypertensive crisis. Even levodopa has been associated with increasing the risk of hypertensive crisis. Let's not forget that, depending on the dose, dopamine-like compound combined initially D1 receptors that cause vasodilation, but then beta-1 receptors to worsen tachycardia, and alpha-1 receptors to cause vasoconstriction. For the serotonin syndrome, too much serotonin will present generally as a patient that is profusely sweating, then is starting to have some dyskinesias with muscle rigidity and particularly myoclonus, so some rhythmic twitching of muscle, and then unfortunately someone who develops life-threatening hypothermia and life-threatening seizures. Too much serotonin will classically be seen not only with TCAs that are non-selective reuptake inhibitors of norepinephrine and serotonin, but also with the SSRIs, the serotonin-specific reuptake inhibitors. Let's also add to this the drug meperidine, an opiate that is antimuscarinic, but also an opiate whose main metabolite through P450's normeperidine is an SSRI. You know, if you want to be complete, you could add also dextromethorphan, which is over-the-counter in cough syrups, and an herbal preparation known as St. John's wort. St. John's wort is over-the-counter as an herbal preparation to treat mild depression. It has compounds in it that are significantly serotonin reuptake inhibitors. So your main message here is MAO inhibitors are not classically used as first-line agents, primarily because of life-threatening drug interactions. So what have they been replaced by, really? Over the years, tricyclic antidepressants, which then have been now also replaced by SSRIs. TCAs still have some relevant points on your exam. Here are 3 major TCAs to have on your exam: amitriptyline, imipramine, and clomipramine. Their mechanism is non-specific blockade of serotonin and norepinephrine reuptake. And although the uses historically has been that of major depressions, phobic or panic anxiety issues, OCDs, well, all these have been totally replaced by SSRIs. So what is left in here? What is left are these points that your board will still test you on, and you might recall some of those actually mentioned in your behavioral sciences. Amitriptyline is still a drug that is classically used for neuropathic pain. And it is used for neuropathic pain the same way as anticonvulsants like carbamazepine or valproate would be. It's important to remember this. We use it, for instance, in trigeminal neuralgias, in people who have shingles, in people with migraine headaches. Imipramine is still used and board tested for its use in enuresis. Imipramine is a drug that decreases phase 4 of slow-wave sleep. Now, the problem I have with this point, I'm sure if you've reviewed already your behavioral science, is the fact that they've revamped the actual stages of slow-wave sleep. I don't know what the boards will do with that statement, but it has been a classic to test you on imipramine decreasing slow-wave sleep phase 4, which is the last phase right before the REM sleep. And it is during this phase that little kids will tend to have enuresis and start wetting their beds. So that was a primary question about imipramine that I have not heard is removed.
Sleep cycle. कसले भन्छ हैन इम्प्रोमेन
from the example, the fact that they've revamped that is classically used for neuropathic pain. And it is used for neuropathic pain the same way as anticonvulsants like carbamazepine or valproate would be. It's important to remember this. We use it, for instance, in trigeminal neuralgias, in people who have shingles, in people with migraine headaches. Imipramine is still used and board tested for its use in enuresis. Imipramine is a drug that decreases phase 4 of slow-wave sleep. Now, the problem I have with this point, I'm sure if you've reviewed already your behavioral science, is the fact that they've revamped the actual stages of slow-wave sleep. I don't know what the boards will do with that statement, but it has been a classic to test you on imipramine decreasing slow-wave sleep phase 4, which is the last phase right before the REM sleep. And it is during this phase that little kids will tend to have enuresis and start wetting their beds. So that was a primary question about imipramine that I have not heard is removed from the exam. So still remember it this way for right now. You know, another effect of imipramine, as we'll see, is to be a strong antimuscarinic. And as such, if all TCA is a muscarinic and alpha blockade, if all TCAs have muscarinic and alpha blockade as side effect, you could also hazard as a guess that with antimuscarinic effect you have urinary retention. Clomipramine, finally, if you still tested on this one, is the fact that it has been used for obsessive compulsive disorders. And clomipramine is really nearly an SSRI. It's so strong, a serotonin reuptake blocker, that it's just about like the next class of agent. So if you test it on TCA, it's more likely for those uses than it ever would be for the use in major depression. You see, muscarinic and alpha blockade is their toxicity, and SSRIs will cause much less, if any, autonomic type of side effect. This is the point finally in the book where we put the 3 C's, coma, convulsion, and cardiotoxicity with Torsades. And it is very classic not only of TCA, as you know well now, but the antipsychotics, atropine-like drug, most antihistamine, drugs like meperidine, and serotonin syndrome with SSRI. To go and prevent and have been marketed. Fluoxetine was the prototypical one, you know, the drug Prozac, paroxetine, sertraline. If I were you, I would put at least citalopram also as another drug in there. SSRIs really have been heavily marketed and very well established as treatment for major depression, obsessive compulsive disorders, bulimia, anxiety disorders, PMDD, and so forth. So as I'm looking at these drugs, think of them as your first-line agents right here. One thing that has always worried me is the issue that we've managed to brainwash ourselves with using SSRIs for anxiety disorders. Look why. Increasing serotonin is increasing a substance that is very excitatory. The actually first side effect of using SSRI are anxiety and agitation. So I don't know about you, but it doesn't make much sense to use SSRIs in anxiety disease. As a matter of fact, guess what we have to add to SSRIs to curtail this anxiety and agitation? You know, the first several weeks, we have to wait for the antidepressant effect to take place. And what do you think would happen if a depressed patient was now made anxious because of their antidepressant medication? You are correct if you're thinking they might actually decide to hurt themselves and attempt suicide, or maybe hurt someone else. And then you know who are they going to blame for actually pressing the trigger on the gun. It's going to be either the fault of Prozac or it's going to be your fault for giving the drug. So classically what is given with the SSRI is a benzodiazepine, a drug such as alprazolam. In which case you start wondering who was really efficacious in the anxiety management of this patient, the benzodiazepine who is used for that or the SSRI. Now, having said this, if you use SSRIs for depression, then after several weeks, when you feel comfortable that your patient is now being managed for the depressive moods, it is safe to taper the dose of the alprazolam off. Other side effects. As a matter of fact, guess what we have to add to SSRIs to curtail this anxiety and agitation? You know, the first several weeks, we have to wait for the antidepressant effect to take place. And what do you think would happen if a depressed patient was now made anxious because of their antidepressant medication? You are correct if you're thinking they might actually decide to hurt themselves and attempt suicide, or maybe hurt someone else. And then you know who are they going to blame for actually pressing the trigger on the gun. It's going to be either the fault of Prozac or it's going to be your fault for giving the drug. So classically what is given with the SSRI is a benzodiazepine, a drug such as alprazolam. In which case you start wondering who was really efficacious in the anxiety management of this patient, the benzodiazepine who is used for that or the SSRI. Now, having said this, if you use SSRIs for depression, then after several weeks, when you feel comfortable that your patient is now being managed for...
Good night yaar, good night. Break भइसक्यो छ यार. मन सुत्छ यार, अब रात धेरै भयो यार. It's time for sleep. म अफ गरिदिन्छु है. कि अझै 2 घण्टा बस्नु ल. अनि 2 मिनेट कुर्छु नि अफ गर्नु ल. This is certain name. This is Assam. And tan. Oh. 37 सब्सक्राइबर पुगाउँछु नि त म. मेरो अर्को जिमेल पनि छ नि त. यहाँ जाने हैन. अनि एड अकाउन्ट निन्जा लाग्छ छैन मलाई अझै पनि. कफी खान बिर्सेँ मैले आज यार. कफी नखाएर हो बल्ल बुझेँ. Is it 215 at 2? It's gone. Subscribe रहेछ यार. आइडी पाइन्छ अब. लगइन गरी के छ हैन. suman.adhikari gmail.com. Subscriber बढाउनु पर्यो नि त. 3 concurrent viewers who is watching me. सुत्ने बेला भइसक्यो हैन. 3 बजिसक्यो. सुत्ने बेला हो हैन. 2:58 निन्द्रा लागेको छैन मलाई. हैन. Who is this? Oh man, password बिर्से यार. के होला पासवर्ड? थाहा छ मेरो पासवर्ड के हो? One concurrent viewers, nobody is watching me. Forget password. के गर्नु त? पासवर्ड बिर्सेँ भने लास्ट पासवर्ड पनि थाहा छैन मलाई to get a verification code first confirm the phone number divided to the account बुवा मलाई किन फाइफावाला पनि छ मेरो गाह्रो छ त गाह्रो छ इमेल एड्रेस ओके थ्याङ्क यू 3 बज्यो 124 हामीसँग लाइभ स्ट्रिममा नयाँ मान्छे जोडिनु भएको छ भने मेसेज टाइप गरिदिनु उज्जवल बाइक उज्जवल त मसँग अघिबाट 10 बजेबाटै मसँग छ अरु कुनै नयाँ मान्छे आउनु भयो भने हैन वेलकम ब्याक टु फेसबुक थ्यांक यू वर्ल्ड लिंक वर्स्ट इन्टरनेट अहिले चल्ला छ Okay, nice. That's important, you know. Who is watching me? उज्जवल हेरेर अझै सुते छैनौ सुत्नु पर्दैन भाइ दुःख लाग्यो मलाई यार त्यो 40 सब्सक्राइबर पुगिसकेको थियो हैन एन्ड अगेन 36 मा आउँदा 4 जनाले एकैचोटी यार दुःख लाग्यो यार दुःख हैन ठीक छ नो वरीज मेरो कन्टेन्ट मन परेन होला आई विल ट्राई टु इम्प्रुभ माइसेल्फ हैन नो हार्ड रुल्स लाइटिङ चाहिँ भएन नि यार बत्ती पनि गयो यताबाट भोलि I will find a new solution for that भएको लाइट पनि बिग्रियो ओके 3 बज्यो अब चाहिँ I think I should leave है भोलि 12 बज्यो अब 3 बजिसक्यो I will have 6 hours 6 7 8 hours sleep up to 11 and 1 hour gap हुन्छ त्यसपछि हैन I think I found something Who is this? उज्जवल सुत्यो तिमी I have a cockroach आज मर्छ यो अस्तिबाट इरिटेट गरिरहेछ यो मर्छ यो कक्रोच अलिकति ब्राइटनेस बढाउनु पर्यो डार्क आएर रहेछ होइन very nice it's totally dark nice गयो सुत्नुपर्छ ल बाई